It is a great honor for me to present Professor Christian Kuhl. Professor Kuhl today is the director of the Department of the Diagnostic and Interventional Radiology in the University of the Hospital of Aachen. Professor Kuhl is an internationally expert in the field of breast MRI, breast cancer imaging and treatment. She is highly recognized, respected, and a pioneer in the field of breast MRI. She has authored or co-authored more than 1,000 papers and conference abstracts. She served as principal investigator in several large multi-institutional studies. She also is a visiting professor in many universities such as the Harvard, the Memorial Sloan Kettering, and the MD Anderson. She's also a member in the group on breast MRI Commission for Standard Accreditation, and many more accreditation and the honorees. And it is really a great pleasure and we are very happy to host Professor Christian Kuhl here at this multidisciplinary meeting. Thank you for coming and being here.
Okay, thank you very much for this kind of invitation. I actually like to be in Israel because I have been here during my time as a medical student. I passed a year at Tel Aviv University and I was working in Kfar Saba Hospital. That's a long time ago, like almost 30 years or so. And so it's a privilege for me to come back now as an invited speaker, big thing to me, to your Congress on Senology. I was invited to give 2 lectures. One today is on breast cancer screening with the obvious focus on magnetic resonance imaging. If we look at the data that we obtained from mammographic screening, that is actually a success story in that we can observe an at least 25% reduction of mortality in women who do participate in mammographic screening. This, of course, leaves a 75% maintained mortality in women in spite they underwent mammographic screening, which practically also tells you why it might be good to look at improved breast cancer screening methods. An important reason why we look for other methods beyond mammography is, for instance, overdiagnosis. Overdiagnosis is defined as the fact that mammographic screening may pick up prognostically irrelevant, non-lethal cancers, cancers which, if left undiagnosed and therefore left untreated, would not progress by themselves to a life-threatening disease. The current estimates regarding overdiagnosis say that about between 10 and 52% of screen-detected breast cancers belong to this group. The broad range tells you that there's a great deal of uncertainty with regards to the exact numbers. But it's certainly true that overdiagnosis does exist. And one reason why overdiagnosis is an inherent problem for breast, not only breast but also prostate and probably also lung cancer, is the fact that, of course, breast cancer is a group of disease. We distinguish different types based mostly on clinical surrogate markers, from luminal A to triple negative, and they differ with regards to their prognostic importance and their likelihood to metastasize, which is probably the same. You should then also realize that while these cancers distinguish genomically, they also distinguish regarding their imaging phenotype. Triple negative cancers frequently appear as, potato-like, well-circumscribed tumors with pushing margins, And on the other hand, the luminal A type of cancer are the ones that actually share the specific architectural distortions that are commonly found in breast cancers. Now, if we use mammography to detect cancers, then we so to speak use okay. So if we use mammography for the detection of breast cancer, what we actually use, wonderful, what we actually use is its ability to detect pathophysiological processes that reflect regressive changes. If you go back to a mammogram, what we depict are architectural distortions that are caused by hypoxia and speculations which are caused by desmoplastic reactions, again triggered by tumor hypoxia, and calcifications which are due to cell death usually. So we depict slowed growth, so to speak, which tells you that the detection of breast cancer in mammography, but as well tomosynthesis, is biased towards slowly growing cancers. That effect has long been known under the name of length-time bias. Length-time bias tells you that a cancer that was diagnosed through mammographic screening enjoys a better prognosis than a cancer of the same size not diagnosed by mammographic screening. In other words, diagnosed in between screening rounds because it became palpable and in interval cancer. You could rename the entire thing and say that mammography associated cancers that are depictable by a mammogram have features that tell you that this is a cancer with slow growth. Overdiagnosis then is nothing else but length-time bias put to an extreme, in that not only deal we with slowly growing cancers, but cancers that do not have the potential to metastasize. That the flip side to this is that mammography is specifically insensitive in depicting biologically aggressive cancers, like the triple-negative cancers, that frequently will not be associated with calcifications, will not be associated with architectural distortions. They just grow like potatoes. So the other problem that is derivable from the same pathophysiological principle is underdiagnosis. That name actually does not exist in literature, but I like to know it, to use it because it's actually comparable. Underdiagnosis in that mammographic screening has a limited sensitivity specifically for rapidly growing prognostically relevant disease. And we know this because we use mammography, or have been using mammography for a very long time already. We know it from clinical trials, like, for example, the DMIS trial, which was done on 50,000 women, and which was the first trial, the first screening trial, where cancers not diagnosed by mammography were counted as false negative cancers and not as new interval cancers. If you do so, and that is the way we rate the sensitivity of imaging studies all over the globe, then the sensitivity of digital mammography and film mammography was quite similar, and it was 40%, and that is even reduced down to 36% in women with ACR3 or 4 breast tissue. In other words, the sensitivity of mammography is lower than desirable, and certainly far away from being perfect. We know it from the large mammographic screening trials because over 30% and up to 50% of cancers identified in organized mammographic screening programs like the EU program are interval cancers. Interval cancer rate is the rate of cancers that are not diagnosed by mammography, although the individual has participated in mammographic screening, but is diagnosed clinically in between screening rounds. And we know, just as mentioned, that the interval cancers are associated with a significantly worse prognosis. And that is plausible because these are the ones that are most difficult to find with mammographic screening. Cancer epidemiology also tells its own story regarding underdiagnosis of cancer by screening mammography, because in spite of many years of mammographic screening, breast cancer continues to be the most important cause of cancer death in women, or second most important cause of cancer death, just depending on whether lung cancer is more prevalent in your country. It is the most common cause of death of all causes in young women, and it continues to be the major cause of life years lost in women all over the globe. So we still have a problem. And that problem has two arms, so to speak. One is overdiagnosis, finding cancers that we don't need to find, and underdiagnosis, not finding cancers that we must find. Which tells you that aim of breast cancer screening in the year 2017 as well is ensure early detection of cancers and their respective precursors that have the potential to kill, and avoid detection of cancers and DCIs that are self-limiting and would not progress. Candidate breast cancer screening methods are listed here, and I would like to focus on these ones in the following. Regarding digital breast tomosynthesis, as you know, this imaging method has been pushed over the past 5 years or so to the fact that by now we oversee imaging, or say scientific data, in almost today even 1 million women, which I think is really an accomplishment on the part of radiologists. The additional cancer yield by additional tomosynthesis is somehow sobering. It is 1.25 per thousand, which is about a 30% increase compared to using digital mammography alone. So the major impact of the results of the Tommy trial from the UK are exactly concordant with this observation. They did not even find a significant increase. The main impact, therefore, of tomosynthesis is actually to improve specificity, reduce recall rates, improve the positive predictive value of a woman that is recalled, and avoid false positive biopsies. So it improves specificity, not necessarily cancer detection rates. And that is plausible because tomo, in a way, uses the same pathophysiological principle of breast cancer detection as does mammography. Contrast-enhanced digital mammography has not so far been used for screening, only for diagnostic cases. We use it in our department, and as you can see, because we depict enhancement, it is possible to identify cancers that would go undetected by mammography alone. Contrast-enhanced mammography does improve sensitivity of digital mammography greatly. So unlike DBT, unlike tomosynthesis, contrast-enhanced spectral mammography will indeed add on the cancer detection rate, but so far there's no data in a screening situation. Also because, of course, using contrast-enhanced mammography is quite an investment in time, use of patient time, reading time, preparation, and things. Ultrasound, handheld, but also automatic ultrasound has been used for improving breast cancer screening. There are quite some studies available that all are concordant in that we do detect additional cancers in the range of an average of 4.1 per thousand. I think the most prominent paper was published by Wendy Berg, who used ultrasound in women with dense breast tissue, and that finding actually matches nicely with the findings of other trials on the same issue. You may note that automated ultrasound was associated with somewhat lower additional cancer detection rate, which I think is plausible. Now, the problem with ultrasound, be it handheld or automated, is the low positive predictive value. For example, in this trial, authors say that an additional 552 biopsies had been performed to identify 30 additional cancers, which is somehow a lot. Another problem with either methods, handheld but also automated ultrasound, is the time it takes to acquire the studies, because the mean radiologist examination time in Wendy Burke's trial was 20 minutes for a screening case. So actually, if radiologist time was the measure and the cost it affords, then screening ultrasound would probably be the most expensive of all diagnostic tests in the entire field of medicine. Interestingly, Wendy, after a couple of years of screening ultrasound, I think she screened her cohort for 3 to 4 years, she received extra money from the Avon Foundation to add MRI to her group. An MRI, a single MRI, in a group of patients who had received annual screening mammography and screening ultrasound for 3 to 4 years in a row. And in that group, the additional cancer yield was 14.6 per thousand, which somehow tells you actually the story. Which brings me to the main topic as I see it, and that is multi-parametric MRI. What drives the current use of MRI for screening? Well, first, it is important to realize, against many allegations saying the opposite, that the diagnostic advantage of MRI versus mammography is independent of a woman's risk to develop breast cancer. The gradient between what MRI can achieve and mammography and ultrasound is exactly equivalent if you have a high risk or a low risk woman. Only that in a high risk woman, that gradient is more frequently needed because that individual will have breast cancer with a higher likelihood. However, breast MRI is expensive, and in a screening cohort, by definition, only a smaller fraction of women will have breast cancer, and only they can benefit from a screening examination. So to ensure somehow a decent return on investment, we enrich the screening cohort by including only women who carry a high lifetime risk of breast cancer, because only the ones that have cancer can benefit. Now that explains how we use MRI currently. We use it for women who have a recent diagnosis of breast cancer to screen the opposite breast. We use it in the follow-up after breast cancer surgery because these women have an increased lifetime risk. Women who have a tissue diagnosis of ADH, LAH, LCIS, women who had a mediastinal irradiation for Hodgkin's disease, because also them carry a high lifetime risk. And then, of course, women with familial breast cancer like BRCA, 1 or 2 mutation carriers of other mutations, but then also women with variable lifetime risk depending on family history. For all of these applications, we now have data available that concordantly say that MRI is far superior to mammography and ultrasound for screening. For women with genetic or familial risk, we have the largest body of evidence, and I stopped collecting this table in 2010. But you should realize that the inclusion criteria in these different trials differ greatly. For example, the first trial that actually came from our group included only women with BRCA mutation. Then Dr. Krieger's trial, 2004, included women with just a vague family history. So it's a very, very broad spectrum of risk. And still, in all of these trials, the sensitivity of MRI was greatly higher than that of mammography. This stems from our multi-center trial where we compared in every woman the sensitivity of MRI versus ultrasound and mammography. And you don't even need a lot of statistics to see that the sensitivity of MRI is substantially superior to other methods. The actual quality metric of the success of screening is actually the interval cancer rate. And it makes me proud to say that the interval cancer rate, specifically also including young women at very high lifetime risk, can be as low as 0 for example, the EVA trial we published in 2010. That is specifically remarkable because as you know, specifically young women with BRCA mutation tend to develop rapidly growing cancers that are very difficult to find that early that an interval cancer rate of 0 or below 10% would result. And that compares with an interval cancer rate of between 30 and 50% for average risk screening in EU screening populations. So we ask ourselves with the EVA trial, what is the respective contribution of the different imaging methods regarding the early diagnosis of breast cancer? Because we all do MRI, mammography, and ultrasound in the same women. That was published 2010 in JCO. And that was the actual aim, was to refine management recommendations. So we looked at the cancer detection rate with each individual imaging method and different combinations. And this is what we found. The sensitivity of mammography alone was 33%, which is actually a nice match with the DEMIS trial. If you look at the data of mammography in average risk women, but with ACR3 and 4 dense breast tissue, which is mostly found in young women who undergo screening for familial breast cancer. If you add ultrasound to mammography, the sensitivity rises to below 50%, which is the exact additional cancer detection rate that was also found in Wendy Berg's trial on using ultrasound for screening in, again, women at average risk of breast cancer. So it all matches nicely. If you do MRI, that actually provides the huge jump of sensitivity, and whatever you do in addition does not matter, because it does not increase the cancer detection rate to a statistically significant degree. The difference between 93% and 100% were due to 3 low-grade DCIS, which were picked up by mammography and went undetected by MRI. So with MRI, we find a large number of additional cancers. Does that not improve the problem of overdiagnosis? Is more diagnosis equal to overdiagnosis? Well, I would not stand here in front of you if I would think this is true. Not necessarily would be my reply to this question, because today too many women die of cancer. If nobody died of cancer anymore, then additional cancers found by new screening method would constitute overdiagnosis. But that's not the case. My take of this is we do not have to detect all breast cancers. We should not detect them all, but we need to find the ones that have the potential to kill. The ones on the right end of the spectrum. Now, as you all know, MRI is not only a diagnostic tool, but it's also a biomarker. It is actually used for a longer time as a biomarker than as a screening tool, of course. We use it, for example, for response assessment of patients undergoing neoadjuvant chemotherapy. And the fact that we can do so is because the detection of breast cancer in MRI is based on angiogenic activity and protease activity. Both is required to yield contrast enhancement at the site of a cancer or DCIS. So the detectability of a cancer in MRI is based on these two pathophysiological processes, and these are tissue changes that are also implicated in carcinogenesis, needed for cell proliferation and metastatic growth. So you could say that the MRI detection of cancers and DCIS is biased towards biologically active, prognostically relevant disease. In short, you could say the better a cancer grows, the better it is able to metastasize, the better will it be visible with MRI. So we have a reverse length time bias, if you want, and that is the exact different spectrum of disease found preferentially by mammographic screening. So that cancer, which is difficult or impossible to see on a mammogram, is beautifully visible on MRI. And that tells you that the imaging phenotype or the the sensitivity profile of MRI is actually a beautiful match to what we actually want to achieve, in that the triple negative ones, the biological important cancers, will be visible with a very high reliability, but you may have false negative low-grade DCIS. Maybe it's good to have false negative low-grade DCIS. This was published in Lancet just 10 years ago, exactly 10 years ago, where we compared the detectability of DCIS on mammography and MRI. Until that publication, people believed that you need microcalcifications to find DCIS, until we showed the opposite, in that the sensitivity of MRI is greatly superior to that of mammography, but the superiority increases, the gradient between MRI and mammography increases with increasing biologic relevance, so to speak, of a DCIS. So we find a load, many non-calcifying high-grade DCIS. If you go back to your own praxis or your own clinical experience, you have to realize that a great deal of high-grade cancers of invasive disease in general is not associated with calcifications. These cancers will probably also have progressed through an intraductal phase, and if they did, then that DCIS has not been associated with calcifications either. That was actually nicely recooked by Liz Morris' group from the Sloan Kettering, where they compared the detectability of cancer and DCIS by MRI compared with mammography, and found the exact same thing. The more biologically aggressive a cancer is, the better will it be seen, and vice versa with mammography. So enhancement on MRI is a strong biomarker for the prognostic importance of a DCIS or an invasive cancer. You could also conclude, although there's no data so far to prove this, that cancers or DCIS that do not enhance will likely represent prognostically unimportant disease. At least number-wise, this is an exact match, because about 20% of DCIS, mostly low-grade DCIS, will not be visible on MRI. You may therefore argue or expect that using MRI alone for screening would help avoid both under and overdiagnosis. So, so far the American Cancer Society recommends to use MRI for screening in women at high risk of breast cancer. That is a guideline that was issued in 2007 and will probably be reissued soon. But even if you look at this, women at high risk of breast cancer, how is this put to practice, that recommendation? Do these women actually have access to MRI for screening? This paper published in JAMA addressed this issue. And this paper investigated data on over 25,000 women who, based on their lifetime risk, would require an annual MRI for screening. And the paper found that only 1.5% of eligible women do indeed receive MRI for screening. Well, that gets me back to that slide here. What drives the current use of MRI for screening? And I would make the claim it is cost, mainly, and cost allocation. of breast MRI, or say the current allocation of breast MRI, is driven by economic rather than medical considerations. And of course, the fact that MRI is not available on a broader scale is its cost and its limited availability, and availability is a function of cost, which is the exact reason why we moved from multiparametric to abbreviated MRI, and I would like to just give you an outlook on this before I close. The aim of abbreviated MRI is to make MRI a real screening tool, because we just realized that all studies that used MRI for screening used the exact same full diagnostic protocol that was actually designed for problem solving. So we aimed at reducing the acquisition time by stripping the pulse sequence protocol down to the exact essential and leave anything else away. Then have, just as the real screening in mammographic screening, have expert radiologists interpret this abbreviated protocol, and look what we found. So this was our full protocol. It took 21 minutes, and we left everything away, but just one pre and one post-contrast acquisition, taking 70 seconds each. We then realized this is pre, this is post-contrast, 70 seconds plus 70 seconds. The patient goes out of the magnet. Okay. What we then do is subtract, the subtracted images, and this is the first post-contrast subtracted or fast image. And then we fuse the images to get a MIP, maximum intensity projection. Many of you will know maximum intensity projection, like from MR angiography or so. This is a technique to fuse several images into one image that gives you the entire picture. So then what we looked at is, how long does it take to read these images, and how sensitive are we, and how specific regarding breast cancer detection. So, for example, we then used the MIP images, this is the MIP image, to find disease, and then went back, if needed, if we find cancer or something that looks like cancer, to the individual first post-contrast or fast images to identify or characterize enhancement based on its morphology. This was published again in JCO 2014 and included, a couple of hundred women with actually only mildly increased risk. This is one of them. Does she have cancer or not? Well, on which side? That is the left. It's the left, okay? So and the right breast, by the way, is normal, okay? And how about her? No. And how about her? On the left. And how about her? No. And how about her? Yes, on the right. How about her? Normal. How about her? Yes, on the left. Maybe two foci. How about her? Normal, okay? So how long did it take you to read this? It's actually difficult to measure. We had a stopwatch. And it was below 3 seconds on average, which included cases where you would say, okay. Time to read, if you had something like that and want to go back to the individual subtracted images, was still less than half a minute on average. So that is really quick, and that is quick because it's high contrast. It's not, you're not in search mode. It's not like a mammogram. It's small, subtle changes may not correspond to breast cancer. That is black and whitish imaging, okay? So, and interestingly, the supplemental cancer detection rate with this quick pulse sequence was 18.3 per thousand. No interval cancers observed, and average size of cancer 8 millimeters. And interestingly also was that, like in agreement with the expectation, we had the additional cancers were skewed towards grade 3 disease. The diagnostic accuracy, actually not expected. We thought, we had expected that we would give away some of the diagnostic accuracy and invest this into access to breast MRI. But surprisingly to ourselves, the diagnostic accuracy was equivalent. Here's one clinical case, a normal, relatively dense full-field mammogram. That's her MRI, and as you see, there's a large DCIS on the right. That's a normal full-field screening mammogram. Here's a small invasive cancer on the left. There's a very dense mammogram, a very difficult ultrasound, took like 20 minutes and a lot of headache, a lot of, intracystic soft tissue, dilated ducts, filled duct, architectural distortions, posterior acoustic shadowing. And she went out with a Biarritz 4 on both sides. And her MRI is negative, and it takes you a second to say so. Okay, so we had an additional cancer of 18, which compares to 1.2 per thousand for additional tomo, or 4 per thousand by additional ultrasound, which then takes a very long time to acquire. We had more biologically aggressive cancers. The PPV actually was good. It was 25%, which is way higher than that of ultrasound, and comparable to that observed with tomo for screening. It requires a table time of 3 minutes. It requires a radiologist reading time of 3 seconds, which compares nicely to 21 minutes for screening ultrasound. You know, it's now moving towards using MRI, non-contrast MRI, because in many cases we don't even need contrast, but just can use the unenhanced images for diagnosis. That is, if you add diffusion to this, may be sufficient. We are just publishing today, I think, our results on using MRI for screening in women at average risk. Pure, you know, no breast cancer associated risk factors. No family history, no prior biopsy, no nothing. And found almost exactly the same thing, additional cancer detection rate 22 per thousand in the first screening round. So in conclusion, it occurs to me that the research directions in breast imaging are moving in very dissimilar directions. For mammography, where we started, we went to digital mammography, to digital breast tomo, to contrast-enhanced spectral mammography, to contrast-enhanced digital breast tomo, it's next kid on the block, to dynamic contrast-enhanced tomo, to contrast-enhanced dedicated photon counting breast CT, which is the current, I think, you know, consideration. With MRI, we had exactly different. We came from multiparametric MRI and now are with abbreviated MRI in a very, very quick examination. Why can't we just use this? So in conclusion, in spite of decades of mammographic screening, breast cancer continues to be the main cause of cancer death in women. Overdiagnosis is actually mostly discussed in the public, but as it occurs to me, it's not the main problem. The main problem is underdiagnosis. Radiographic breast imaging, which is mammography but also DBT, has a technology inherent bias to detect slowly growing cancers, which will then add to overdiagnosis but also be associated with underdiagnosis. Overdiagnosis is probably not a consequence of screening per se, but is a consequence of poor structural imaging of cancer. MRI has a technology inherent bias to preferably detect cancers with active angiogenesis and protease activity and desirably low sensitivity for low-grade DCIS. An abbreviated MRI has the potential to make MRI suitable for mass breast cancer screening. Thank you very much.
Thank you, Professor Kuhl, for a very, I think, exciting, important, and I think also challenging for some of us, for some of the ideas. Do we have time for a few questions? Okay. Yes, Dr. Sela.
Okay. Comment on gadolinium deposition in the brain. You know, I don't know how my personal take of this is that it will be similar to NSF. We had a huge hype around NSF, which is nephrogenic systemic fibrosis. You may remember almost exactly 10 years ago, 2007, 2008, there was a big uproar that can't use gadolinium contrast agents due to NSF. There were a lot of conferences on this, a lot of publications on this, and it completely disappeared. I mean, the only remaining issue, or say the only remaining thing of NSF is that we should use macrocyclic contrast agents rather than linear contrast agents, which we do. anyway, for breast. Now it comes across this gadolinium accumulation. Accumulation almost sounds as if there were like piles of gadolinium in the brain, which is of course not the case. It's an imaging observation that if you inject several amounts, I mean, if you do contrast enhanced MRI in a row, that then what you may observe in patients who have received like 10 times gadolinium, a subtle signal intensity increase of basal ganglia, and specifically cerebellar ganglia on pre-contrast T1. So far, nobody has found a neurological symptom associated with it. And the most important, say, conclusion is to use macrocyclic contrast agents. Well, of course we do. And I don't know how your impression is, but where there was a peak of papers and publication and hype around this like 2 years ago, it was already on the decline last year, and I have not heard anything of it. I mean, the year's young still, but this year. So it will probably have the same development. My personal take is, if you could see the stuff that is accumulated in the brain more often, we would be surprised to see what type of medications, for example, or traces of medications you accumulate in the brain. The problem with contrast agents is that you can see them on MRI. If, for example, somebody investigated how much of the aspirin or paracetamol remnants we accumulate in the brain, only that they don't give contrast on MRI. So my impression is I personally don't care at all.
Professor Kuhl, just a quick question. If you weed out the prevalence screen from all the literature on MRI, for example, in Wendyberg's study, she saw 14 per thousand on a prevalence screen MRI.
Right.
If you average out only incidence screen, because you're comparing a prevalence screen on MRI with incidence screen of many years of mammography screening, how do the figures match up? Because your ever bar will have a reduction then in your incidence of MRI-detected lesions.
Right. If you, in that paper that will be published this month, I think even today, we did not a single screen. We did 7,000 women years. So we do have incidence data.
But if you exclude your prevalence screen from that incidence data, you know that your prevalence screen is a disproportionate.
No. You have to first of all, let me just finish that sentence. We do have incidence data, and as you would expect, we have a steep decline. I mean, we have a 22% per mil cancer detection rate in the prevalence screen, and then it drops down to, I think, 7 per mil in incidence. But the most important finding is that we had a cancer rate of 0, interval cancer rate of 0. So if you keep in mind that with mammographic screening and the big screening programs, during incidence screening, the interval cancer rate, the expected interval cancer rate is 50% of cancer detectors. That actually matches nicely up.
So my next question then would be, what are your feelings about the PBS study, which is envisaged now for the European Union? My personal breast cancer risk, which Suzette and Ord from the European group are putting together. I'm sure you're aware of it.
Okay. Well, I think that they move in the correct direction in that we have tailored screening, but the problem here is that if you take all the data that is available and fuse it, or the conclusion is actually that the most sensitive method, irrespective of personal risk, is MRI. And you could of course say that it's not worthwhile offering a woman at average risk an MRI because with all likelihood she will not have cancer during her lifetime. Then the current data prove you wrong. That's the problem. Yeah. So doing the best is, of course, doing the most expensive, which is MRI. If you use a brevet MRI, then we cut down the cost considerably. That's not going to be the most expensive. We're left maybe with the issue of contrast accumulation. That is actually more. But otherwise, I think using a screening method that does not imply ionizing radiation at all and is far more sensitive and as specific as screening mammography, I don't know a good justification not to use it. Yeah. Could you the microphone? Or I repeat whatever you say.
Thank you very much for your lecture. I do have a few concerns that I didn't pick up from your lecture. Definitely there's more diagnosis, and maybe we can, at some point, differentiate between those that are relevant or non-relevant, but I'm sure that, as of now, if you see a suspicious lesion, you will biopsy it, right? So my main point is that for an examination to become more common, it should be that there is some kind of benefit. You did not show any benefit in overall survival or even disease-free survival. And we know from other studies that when MRI was used, when patients were diagnosed, that there was actually an increase in mastectomy rates by about 20% without any studies showing that it had any kind of benefit from it. Mm-hmm. So why in a sense, what you are increasing is the overdiagnosis rate. You didn't talk about the specificity, which sometimes causes doing too many biopsies. And in places where you do not have high availability, those patients, usually when they have a diagnosis on MRI, they are sent back for ultrasound to try to biopsy under ultrasound, and then the patient goes back and forth, which, of course, for the patient is terrible.
Okay. Can I just try to get there are three different aspects that you raise here. One is lack of evidence on survival. Second is specificity. Third is availability of biopsy method. To start with survival. First of all, there is evidence on improved survival in women at high risk of breast cancer, who were the first ones who underwent MRI for screening, that there is improved survival.
I'm talking about the average patient, not the high risk patient.
Okay, well, let me just, of course, today will be the first evidence on using women at average risk. And it will take a while until we have data on survival. But let me just finish that sentence on women at increased risk of breast cancer. Women who have a high risk of breast cancer were the first ones who were offered MRI for screening. If you do so, there is now 4 papers available that prove that they have an improved survival compared with women who, in the same situation, high risk of breast cancer, did not undergo MRI for screening. But I think it is important to realize the following. I do not think that in the year 2017 it is advisable to wait for evidence on survival before you can introduce a new screening test. Why is that so? Well, simply because we have evidence from the mammographic screening trials. Let me explain. We have evidence from the large mammographic screening trials conducted in the 1970s that mammographic screening improves survival. You would agree with that, okay? Good. Now, another way to summarize the findings is early diagnosis of breast cancer is useful because it improves survival. Early diagnosis, however achieved, is useful. It's not mammography. It is early diagnosis, earlier than palpable diagnosis of breast cancer. That improves survival. Now, if we today can show, or you could, that an imaging method that we compare in a head-to-head comparison to mammography, and can show in a head-to-head comparison, intra-individual comparison, that imaging method, be it ultrasound or MRI, can add or triple, double or triple the cancer detection rate compared to mammography, what would you expect to happen with survival? It will, of course, have an impact on survival. You could even say that even if you use the data on the mammographic survival benefit, will likely underestimate the survival benefit that is expectable if you use MRI for screening, simply because with mammographic screening, we consistently miss the rapidly growing cancers. So you today, in the year 2017, you can use the survival advantage data from mammographic screening, combine it with the intra-individual cancer detection rate data on the comparison of mammography with ultrasound or MRI, and have cancer epidemiologists calculate reliably the survival benefit that you can expect. Of course, you can recommend your own wife, for example, to say, wait until like in 20 years from now, if at all, we will have survival benefit data for MRI for screening. But I would not behave like that. That's for one. The second, specificity. Oh yes, it has been a mantra almost. People always were saying, you know, we see so many things and many of it is not breast cancer. That's true, but that is only a side effect of the fact that people were using MRI for breast cancer diagnosis that were not trained to do so. For example, I don't know how it is in Israel. It may be similar. I know from Germany that a radiologist can have the license to use MRI for breast cancer diagnosis if he or she sees 30 cases per year. That compares to that same radiologist needs to see 20,000 mammograms per year if he or she wants to participate in screening mammography. That shows you the substantial gradient that radiologists have regarding their expertise in reading MRIs versus mammography. Or let's put it this way: if you had a if you are a radiologist, it would work with a radiologist who sees not more than 30 mammograms per year. What would you think would the false positive rate be? Now, all the data that have been published, the ones by our group and many other groups, prove that the positive predictive value of MRI is equivalent to that of mammography. It's the same. It's not lower. So specificity is not an issue anymore. And third, biopsy, you're completely right. You cannot start right now doing something like that in your country, simply because you're not enough trained radiologists and not biopsy possibilities. But that has been the same before people use screening mammography. That comes with practice. Okay, I think
Thank you very much.